A prophylactic antimicrobial agent should be used only when indicated, and selected based on its efficacy against the most common pathogens causing SSI for a specific operation and published recommendations. The initial dose of prophylactic antimicrobial agent should be administered by the intravenous route, timed such that a bactericidal concentration of the drug is established in serum and tissues when the incision is made. Therapeutic levels of the agent in serum and tissues should be maintained throughout the operation and until a few hours after the incision is closed. The use of antibiotics preoperatively can reduce the rate of infection, particularly wound infections, after certain operations. For most procedures, second-generation cephalosporin, which has a moderately long half-life and is active against staphylococci and streptococci, has been effective when given intravenously 30 minutes before surgery. Antibiotic prophylaxis before elective colon resection. The human colon and distal small intestine contain an enormous reservoir of facultative and anaerobic bacteria, separated from the rest of the body by the mucous membrane. In the past 25 years, clinical trials have demonstrated that to substantially reduce septic complications after elective colon surgery, antibiotics must have activity against both colonic aerobes, e.g. Escherichia coli, and anaerobes, e.g. Bacteroides fragilis. Today, approaches to mechanical cleansing differ widely. Modern approaches include standard outpatient mechanical cleansing with dietary restriction, cathartics, and enemas for a 2-day period, or whole gut lavage. Most surgeons use both antibiotics and mechanical cleansing for preoperative preparation before elective colon resection. The use of outpatient bowel preparation is increasing, however, patient selection is critical, and education is needed to reduce the rate of complications. With an electrolyte solution of 10% mannitol, Fleet's phosphosoda, or polyethylene glycol, done the day before the operation. Antibiotic prophylaxis for appendectomy. The pathologic state of the appendix is the most important determinant of postoperative infection. Wound infection after appendectomy for perforative or gangrenous appendicitis is 4 to 5 times higher than for early infection disease. Because the pathologic state of the appendix often cannot be determined before or during operation, a parenteral antibiotic agent is recommended as prophylaxis in all patients. Regimens with activity against both facultative gram-negative bacilli and anaerobes are more effective than those active only against aerobes. Antibiotic prophylaxis in urogenital surgeries. Antibiotic prophylaxis is recommended in transrectal prostate biopsy, in ESWL, in PCNL, endoscopic ureteric stone removal, and highly recommended in TURP. This is to prevent bacteriuria, UTI, and subsequent urosepsis. Gram-negative bacilli and enterococcus are the predominant organisms. Cefazolin is recommended drug and ciprofloxacin the alternative antibiotic. Antibiotic prophylaxis in upper GI surgery. Antibiotic prophylaxis is recommended in gastric surgeries including gastric bypass and small intestinal surgery. Predominant organism include gram-negative bacilli and gram-positive cocci. Preferred antibiotic for prophylaxis is cefazolin and clindamycin, and aminoglycosides being the alternative regimen.